Hi, and welcome to Big Time Care for Growing Bones. This is the second part of a two-part series on common pediatric orthopedic problems in kids. In the first segment, I went over some common problems in newborns and toddlers, and today I'll be going over some of the most common pediatric orthopedic problems that we see in growing kids. For those who are new to this two-part series, my name is Eleaine Tran. I'm one of 8 pediatric orthopedic surgeons at Cohen Children's Medical Center at Northwell Health. You can find me at one of my many office locations in Long Island and Staten Island. In Long Island, I'm in New Hyde Park, Belmore, and Bayshore. So during the first lecture, I touched upon some of the factors that make kids so special in orthopedics. These factors include, but are not limited to, their growth plate, which allows their bones to grow and get taller and bigger, the periosteum, which is a lining around the bone that's extra thick and extra protective and provides a lot of nutrients for kids, cartilage, which they have more cartilage than bone than adults, and their remodeling potential. So today, again, we're talking about more common problems in growing kids, so in the school age range and in teenagers. And more specifically, for school age kids, we'll talk about growing pains, which we see all the time, severs, apophysitis, Osgood-Schlatter's, and buckle fractures. Don't worry about those names, I'll explain exactly what those mean. And in teenagers, we'll talk about fractures in general, not any specific fractures, but kind of what to expect if your kid has an injury or a fracture, ankle sprains, back pain, and finally scoliosis. So starting out with growing pains. So this is a really common problem that we see in the office. Growing pains is a term that is used to refer to pain in the lower extremities of growing children. Most typically, it is in both legs. Kids will complain of pain in both legs, and it does not have to be a specific area. Sometimes it's around the knee, sometimes it's around the shin bone or the ankle, or sometimes the whole leg below the knee. Although it is typically both legs or bilateral, it can be just one side or unilateral in about 15% of cases. Typically what we'll see is that kids will complain towards the end of the day, especially if they've been really active. They'll complain, right before bed, or sometimes they'll wake up in the middle of the night with pain, which can be really alarming for parents because, they're sleeping and all of a sudden they wake up in pain. Generally, it responds very well. The pain responds very well to massage. And sometimes over-the-counter medications like Tylenol or Motrin if the pain really doesn't get better. Things to look out for, which are not common or not typical of growing pains, would be if there is an associated fever, if there's swelling or redness around the legs, if it's associated with a previous injury, those would not be consistent with growing pains. The other thing is that kids usually don't slow down during the day because of it. So we see that kids are very active and running and they're able to do everything, able to play with their friends, play at school, but then it's really towards the end of the day that they have this pain. We can see it happening anywhere from, age 2 to 12. We don't know exactly why it happens. It is not associated with growth spurts, but it does happen in this age range. And once the bones are fully mature, it'll no longer happen. As far as what happens if you come into the office to see us, so usually you'll be referred by your pediatrician if the pain has been going on for quite some time. Your pediatrician may or may not have ordered some blood work just to rule out certain things like any inflammatory conditions or any other issues. And then in the office, if there's anything that's slightly atypical or just a little unusual, we may order x-rays of the legs to see if there's any changes in the bone or the growth plate or the joint. But typically, the treatment for this is really just reassuring your kid that the pain is okay, and massaging the area, and then occasionally, if necessary, over-the-counter pain medicines. So the next problem is Sever's apophysitis. So this is one of the most common causes of heel pain that we see. It's usually in kids who are a little bit older, so around age 8 to 15. And what it is, it's an inflammation of the growth plate by the heel bone. So on the pictures that you see here, there's a cartoon diagram on top and then an x-ray of a foot on the bottom. So the cartoon diagram kind of labels out some of the things. So this is your heel bone, which is called the calcaneus. And there's a big muscle, your calf muscle, comes down, becomes a tendon called your Achilles tendon, and it attaches to the calcaneus bone right by the growth plate. And on the x-ray, the way that the growth plate shows up is this dark line here. So I don't know if you can see my arrow, but the growth plate is made out of cartilage, and so it shows up as this dark line on the x-ray. So what it is, it's an inflammation of that growth plate of the heel bone, and it's from repetitive stress. We can see it in kids who are very active, who are running a lot, playing soccer. You may come into the office and kids have been having pain maybe on just one side, or it could have been both sides, or it was one side, now it's the other side. You know, it's not uncommon for it to kind of migrate. And what we'll see on exam is that sometimes there's a little swelling in that area, not typically too much swelling, but the most common thing is when we squeeze that heel bone, that's where the pain is, and the pain is all localized in that area. Treatment for this is relatively straightforward, so it's just managing symptoms. The good news is that the pain goes away when the growth plate closes, so it's not a forever condition. But the frustrating thing is that, you know, if it starts at a younger age, then, you know, you may have to do these things to try to prevent the pain from coming back until your kid becomes older and the growth plate closes, which is around age 15 to 17. So some things you can do, we always recommend these over-the-counter gel heel cups. So there's a picture of them on the left, and essentially you're just adding a little extra cushion to the shoe. You want it to be nice and soft and squishy in the middle. Usually it's like a silicone pad. I have seen some over-the-counter before that are hard, and you don't want hard ones, you want soft ones to provide a little extra just cushion in that area. Stretching the calf is helpful, so stretching the muscle that attaches to that growth plate is very helpful. And then putting ice on the area can help, taking some anti-inflammatories, and then if necessary, limiting activities for a little bit. So your kid's not going to do any damage by continuing to play if they have this condition and it hurts a little bit. But I wouldn't recommend playing through horrible pain where now your kid is limping with just walking and normal activities. So how much you limit your kid's activities is really dependent on how symptomatic he or she is. And sometimes, you know, kids do need to sit out for a little bit if the pain is really bad. But again, good news is that it doesn't last forever. It's just a type of pain that occurs when a kid is still growing and their growth plates are open. So the next thing, it's a similar condition except in a different area. So something called Osgood-Schlatter's. This is a very, very common cause of knee pain in growing adolescents. We typically see it happening in the pre-adolescent growth spurt, so around age 10 to 13 in girls and 12 to 14 in boys. And what it is it's another growth plate, except this growth plate is in the front of the knee. So in this picture, in this cartoon diagram, you can see kind of like the muscle of the thigh, so the quadricep muscle, which then attaches to the kneecap here, which is called the patella, which then has a tendon, the patellar tendon, that comes down and attaches to the shin bone, which is the tibia. at the spot called the tibial tubercle. So it's this area right here where I'm trying to circle with my mouse that gets inflamed and becomes painful. And it's a similar condition where it's from repetitive stress in that area. Typically kids are really active and like running or playing sports like soccer, or they're doing a lot of jumping activities. And what kids will come in with is they complain of swelling directly over that bony area, pain over that area, and sometimes even a bony prominence in that area. And what we'll see in the office is that the whole knee exam is benign, meaning there's no like fluid in the joint. There's no problems with the ligaments or with how the knee is moving. It's really just pain localized in that one spot. If it's more symptomatic on one side, it may actually be swollen. And what it is, it's irritation of that growth plate from the repetitive stress. Sometimes from recurrent repetitive stress, you can have a little bit of like a bone spur or an extra bump or like an ossicle that'll develop. Depending on how severe the symptoms are, we may or may not get x-rays. X-rays, which there's an example of one up top here, they show that the growth plate is open because it can only happen when the growth plate is still open. But they can also show like an extra little fragment, which I think you can see here in the front, this little circle. This little fragment here, which can develop from recurrent stress in this area over time. There's no need typically to ever have to go in and take out that fragment, unless if it was something where as an adult it was still bothersome, but it's not typical for us to need to do that. And again, similar to Sever's apophysitis, the good news is that the pain is not forever. It goes away when the growth plate does close. So again, it's another thing where it's about managing symptoms with the treatment with supportive measures until the growth plate closes. But it is something that can happen on one side, on the other side. It can come and go. It can be on both sides. So understanding how to manage it is really important. We're going to do similar things to the Sever's apophysitis. So activity modifications based upon how severe these symptoms are. So if it hurts a little bit, then it's okay to keep playing. If it hurts a lot and now you're limping, on and off the field, then I would recommend, a short period of rest. Icing the area and then taking ibuprofen can help with the inflammation. Stretching, so stretching your quadricep muscle, which is that muscle in the front of the thigh, stretching your hamstrings, which is the muscle in the back of the thigh, to keep the knee nice and balanced. And then some people will try certain things like taping. So you could see like an athletic trainer or a physical therapist where they can apply KT tape to the front of the knee directly over the tubercle. And the thought process behind that is by placing the tape across, it disperses the forces across the area rather than having all the forces come down directly onto that tibial tubercle. There's also patellar straps that you could try out. These are easily found over the counter or ordered online, which do the same thing as KT taping. So next, I'm going to talk about buckle fractures. The age range for this is all over the place. It can happen in young kids, in preteens and adolescents. And what it is, it's a special type of fracture that only kids can get. Adults don't get this fracture. It typically will be from some sort of fall onto a wrist. The wrist is the most common area where we see it. And a lot of times the wrist itself doesn't look that bad. So the kid will be able to move their arm, they're moving their wrist, they can even use it, but it may be a little bit swollen, maybe a little bit painful if they put pressure on it. But overall, it doesn't look like crooked or deformed, or there isn't typically like a huge amount of swelling or bruising. So the clinical picture can look a little bit benign. But usually what will happen is because of persistent pain and swelling in that area, then parents will take their kid to like an urgent care, to the pediatrician, maybe a couple days later, and get an x-ray, and the x-ray will show a buccal fracture. And so what a buccal fracture is, it's a fracture of the bone. It's truly a fracture, but rather than a complete break of the bone that you would typically think of, it's just a wrinkle of the bone. So I like to explain it as like a can of soda. So if you take a can of soda and you just crumple it a little bit, and now you have a wrinkle in the can, and you can move the can together as one piece. It's not like tilting or anything like that. Versus cutting a can in half, which would be a complete fracture. Now you have two pieces that are kind of moving separately rather than one piece moving as a whole unit. And so on this picture in the middle, you can see this is an x-ray of a wrist. So all these little bones over here, this is actually like the wrist joint. There are 8 little wrist bones. But I'm talking about this bone here, which is the radius, which is one of the forearm bones. So this is the bone on the thumb side. And then on this part here, this is called the ulna, which is the bone on the pinky side. And whenever there's a break that's close to the wrist joint, we still call it a wrist fracture. So it's a distal radius buccal fracture. And you can see if you follow the outside border and kind of come down right here, there's a little wrinkle. Same thing here, there's a little wrinkle in the bone. And this is just like a cartoon diagram of a buccal fracture. Now, not every buccal fracture is the same. So there are more stable ones where, again, the whole can of soda is moving as one unit, and there are more unstable ones where there's a wrinkle in the bone, but then the fracture line does show like a crack all the way across, maybe on one of the views. And those unstable ones can potentially tilt or displace or angulate over time. So there's different ways that we can treat it. Everyone is different as far as the way that they manage buccal fractures, but very frequently you'll see kids are put either into like a wrist immobilizer, like this picture on the right, which is a brace that is removable, versus a cast. So what I typically do is I put kids into the wrist braces or the wrist immobilizers if it's a stable buccal fracture, so there's only the wrinkle, but the fracture line doesn't go all the way across, and doesn't have the potential to shift or move. So I would keep you in the wrist brace for about 3 weeks to keep you protected. You can take it on and off for showers and washing your hands, and also working on moving your wrist. Versus if it's more of an unstable fracture, then I would put you into a cast because I want to try to prevent the fracture from moving or tilting. The cast would be on for 3 weeks, but a cast is like a circumferential wrap with a hard material. Usually now we use something called fiberglass. In other places, or previously we would use something called plaster, which is heavier and a little bit bulkier, but with the fiberglass, it's wrapped all the way around. So it's not something that you can take on and off, but it does give you like circumferential protection versus the brace, which has a hard strut in the bottom of your wrist and a hard strut on the top of your wrist. That gives you equal amount of protection for those stable buccal fractures. Now moving on to some common problems in older kids, so in more teenagers. I'll first talk about fractures. And again, this is just like a broad overview of fractures. This could happen in any age group, but I just wanted to go over kind of what to expect if your kid has an injury. So each type of injury might result in a different type of fracture. What I mean by that is, like, if a kid falls from a standing height, they may not have as severe of a fracture, and they fall into their wrist, they might have like a minor wrist fracture or even a buccal fracture, versus a kid who's on a monkey bar and they fall and land onto their arm. They might break the humerus bone and have an elbow fracture, versus someone who, is in a car accident and there's a lot of, we call it a lot of energy that goes through the bone. So it's like a high speed mechanism. It's a high impact injury to the bone. Then you might break, one of the long bones, like the femur bone, which is your thigh bone, or the tibia, which is your shin bone. And all of these fractures are treated differently based upon the type of fracture it is and also the age of your kid. So in general, we try in younger kids to treat fractures without surgery. So if your kid has an injury, has a fall, something happens, and say the arm is swollen, but they're able to move it around, what I would recommend is, if they're having pain, you're concerned for a fracture, you could certainly go to an urgent care where they could get x-rays. Versus if your kid has a fall on the arm, but the arm is obviously crooked, or a fall on their leg and the leg is obviously crooked, then I would take them to the emergency department where they would be seen by one of our providers where we would get x-rays. And in younger kids, if it's something where we think we can treat in a cast, we will try. So once your kid's been diagnosed with the fracture and it's in a bad position, then we may perform a procedure called conscious sedation, where it's not full anesthesia, but your kid would be like semi-sedated. They're still breathing on their own, but they're relaxed enough where we're able to kind of push on the fracture, manipulate it, and then put a cast or a splint on top to hold it in place. We'll do this for, tibia fractures, for forearm fractures. For a shoulder fracture, we may not even do anything. We might just put them in a sling, just depending on how it looks. And then we would see you in the office and monitor closely to make sure that the alignment of the bone still remains okay until there's signs of healing. And then we would transition out of whatever immobilization or cast and kind of guide you through the whole process. Now, if it's something where the kid is older, so say they have a forearm fracture and growth plates are closed and they're more like an adult, then these typically do require surgery. And so we would potentially set you up for surgery, to be added on through the ER the next day, or potentially have you go home if there's too much swelling, and have you scheduled for surgery maybe a week or two later once the swelling has come down. There are some fractures that you would have to have fixed right away. So in older kids, a femur, the thigh bone, if that's fractured, that's something that we would fix. And the way that we fix it is really dependent, again, on the pattern of the fracture and also how old your kid is. So for young babies, we would put them in a little harness. And slightly older kids, we would put on typically like a body cast, which is called a spica cast. In young kids who are still growing, we would put like flexible rods that go into the bone to hold it in place but avoid the growth plate. In older patients, we might put a plate on depending on the fracture pattern, or put a rigid rod that does go through like the top and bottom of the bone. But you don't need to worry about the growth plate at that time because the growth plate would be closed. But again, fractures are just treated so differently based upon the pattern, the bone it is, and the age of your kid. But best advice is if there's something that's obviously crooked, I wouldn't waste time going to urgent care. I would go to the emergency department because more than likely your kid would need some sort of procedure, whether or not it's just a procedure in the emergency department to have it reduced and have a cast put on versus surgery. Now talking about ankle sprains, so we see this very commonly. Ankle sprains happen when a kid twists their ankle when they're stepping down on the ankle. So usually it's what we call an inversion injury, where if this is like your right foot and you're stepping down and you roll it in, that would be inversion, versus eversion is going the opposite way. And these injuries can look really nasty. So usually kids get really swollen after ankle sprains. They get all black and blue. The bruising, the ecchymosis, the black and blue, it can migrate and move from just around the ankle to kind of down tracks towards the foot and the toes. And so it can be alarming because you normally think that wherever the bruising is where the injury is, and now it's all along the foot. But we usually see the bruising kind of move and migrate just with gravity. And so the picture on the left shows a typical picture of how a foot might look after an ankle sprain. And then the diagram on the right shows the different ankle ligaments, which aren't so important for you to remember, but there are ligaments on the outside, the lateral side of the ankle, which would be injured if you invert your foot because you're stretching the outside. And then there are ligaments on the inside of the ankle, which would be injured if you evert your foot because you're stretching the inside part of the ankle. What you would do when you come in, we would see you. So typically, if there's a lot of swelling and bruising and you're having a hard time, kids are having a hard time walking on the foot, you may have already gone to the ER or to the urgent care beforehand, and they most likely will give you some sort of brace or like an air cast or sometimes even a splint, and they'll tell you to stay off of it, don't walk on it, and then give you crutches. Now what happens when you come into the office, we'll take down that immobilization. If there were x-rays done in the ER or the urgent care, we'll review those x-rays. If not, then we would kind of assess the ankle, see where you're having the pain, and then decide whether or not x-rays would be needed. So again, there's different severities of ankle sprains, from where the ligament is not torn or stretched to the ligament is stretched but does not have a tear, to where the ligament is completely torn. And usually your pain and difficulty walking and swelling and bruising is associated with how severe the ligament is injured. So when you're in the office, what we'll try to determine is whether or not you have any pain over the bone. If there is any bony tenderness, then we would typically get an x-ray, unless if the x-ray has already been ordered. Versus, if it's really just around the ligament, is isolated to one of the ankle ligaments, then an x-ray may not be necessary. But if there's any concern, then we would get x-rays. And there are also specific x-rays we can get where we stress the foot to try to stress the ligament to see if there's a gap in the joint when we stress the foot in a certain position. If you're still having pain 6 to 8 weeks after the initial injury, then an MRI might be indicated at that time, just to look for if there's any tendon injury, or if there's any injury to the cartilage, something called like an osteochondral injury, or if there is an injury to the ligaments that connect the bottom of the tibia and the fibula together, called the syndesmosis. But an MRI is not typically indicated when you first come in, as long as everything else looks consistent with an ankle sprain. As far as treatment for an ankle sprain, so rest, so kind of the typical RICE that you hear, so rest, ice, compression, and elevation. So I always tell patients that whenever there's an ankle or a foot injury, there will be a lot of swelling associated. Even once everything's gotten a little bit better and the ankle or foot doesn't hurt anymore, because with gravity, it just pulls the fluid down, and so you can get a lot of swelling there. So it's important early on to keep the foot up and elevated to try to help minimize the swelling. A boot can sometimes be helpful for the first 1 to 2 weeks, but in general, early mobilization rather than long-term immobilization with like casting or a long-term boot is better for your ankle sprain to heal. And then I would also give you a prescription for physical therapy. I usually suggest for you to go one time in person, if not the full time in person, it's up to you, but at least one time in person to learn some exercises to rehab your ankle, because we want you to learn to strengthen the muscles around the ankle to, one, allow you to return to activity sooner, and two, to prevent future injuries down the line. Now moving on, so talking briefly about back pain. So back pain in the past was thought to be really atypical in kids and adolescents, but we actually see it quite frequently now. It can be activity related or inactivity related. It can be postural or from the heavy backpacks. It's hard to say, but we do see a lot of back pain in the office. When you first come into the office, what we'll do is get a good history to try to figure out what makes the pain worse and what makes the pain better. We'll examine you to make sure that all the muscles that are innervated by the different nerves coming out of your back are working properly, that you're not having any numbness, tingling going down the arms or legs, or any like burning or radiating pain down the arms or legs. That might be a sign that maybe there's a nerve problem rather than just like pain around the back. If there is concern, then we would start out with x-rays to look at the alignment of the back. So sometimes we can find something called a spondylolisthesis or spondylolysis, which is just where if we look at your back from the side, so if you see this x-ray here, the one on the right, this is a side or a lateral view of the spine. And when we look at the lateral view, the spine should line up. All the little squares should line up on top of each other. They shouldn't be, one shouldn't be like translated in front of the other. And so we can sometimes see that the bone is like slightly translated in front of another bone, and that would be called a spondylolisthesis. And that can be a cause of back pain. But overall, we're just looking to make sure that everything on the x-ray looks normal. Sometimes we can see if there was like, is very uncommon, but like if there was a mass or something that was in the bone, it can make this little circle. So these are called pedicles here, like this little circle and this circle here. They're called pedicles. It can make the pedicle kind of disappear on one side if there's something there kind of like growing in the bone, but that's very uncommon for us to see that. But the x-ray is just kind of like a scout view to see if there's anything that might be a cause of the pain. Now, if your exam is otherwise normal, your x-rays are normal, and the pain seems to be more muscular in nature, then typically I would recommend physical therapy to work on stretching and strengthening the back, to work on stretching your hamstrings, working on strengthening your core to help support your back. And that would be done first before jumping to an MRI. So a lot of people will come into the office wanting an MRI, or maybe the pediatrician thought that maybe there was an MRI that was needed. But typically, as long as the exam is normal and x-rays are normal and there's no what we call neurologic symptoms, then we would wait on the MRI until you've done a course of therapy to see whether or not you respond to that. But certainly if there's anything concerning on exam, anything atypical or any exam findings that would suggest that maybe one of the nerve roots is being bothered by like a herniated disc or something else, we would certainly get the MRI at that time. Now, last topic for today, I'm just going to briefly go over scoliosis. So I'm going to talk about idiopathic scoliosis. So scoliosis is a curve in the spine when we look at you from the front. So this x-ray on the left is an x-ray looking at the patient straight on. And you can see that the spine, which is all the little squares in the middle, has a curve. And so if there's a curve more than 10 degrees, we call that scoliosis. If there's a small curve but it's less than 10 degrees, and it would not look anything like this x-ray, it would look very minor, we call that more spinal asymmetry. And so the reason why I mentioned idiopathic scoliosis is because this is a very specific type of scoliosis that affects kids who are otherwise healthy. There are other types of scoliosis that we can see. I'm not talking about today, but I'll briefly touch on, like neuromuscular scoliosis, where the kid has an underlying muscle condition that causes the muscles to be weak or tight or spastic, and that is what drives the scoliosis. Or there can be like an underlying connective tissue disorder where all the joints, everything they're slightly loose, and it's associated with the syndrome, and we'll see scoliosis associated with that. Versus idiopathic scoliosis happens in kids who are otherwise healthy, and we don't really know what causes it. That's why we call it idiopathic. And we can see it a higher incidence in families, so we'll always ask you if there's a family history of scoliosis. And typically, this is something that your pediatrician will check your kid for routinely. If they see a little bit of asymmetry, then they might decide to continue to observe until the next year, or send you to our office to be seen and evaluated. And so what the pediatrician looks for are clinical signs of scoliosis. Usually they don't have the x-ray, like right in front of them, but they're very good about sort of picking up any subtle changes. So the clinical photos in the middle and on the right show a scoliosis in a more extreme case or in a more severe case. So some of the clinical signs that you can see are shoulder asymmetry, so maybe one shoulder is higher than the other. The waist can have an asymmetry, so depending on the direction of the curve, you can see a crease on one side versus the other. So here there's a waist crease. Also, this patient is shifted, so the whole trunk is kind of shifted one way versus the other. Kids might feel that one leg is higher than the other, or that one hip is higher than the other, but it's not that the legs are uneven, but it's because of the scoliosis, the curve in the back, that causes the waist crease to look different and for it to look like a hip is higher than the other. And then when your pediatrician asks you to bend forward and they take a look at your back, what they're looking for is a rotational difference. And the reason why they're looking at that is because scoliosis, we get x-rays, which are a 2D picture of a 3D structure, but scoliosis is a three-dimensional deformity or change. So you'll see an S shape like this and this when you're looking from the front, but when your kid bends forward, that S is actually associated with a rotation. So on the picture on the right, you can see the kid bending forward, and the right ribs look higher than the left ribs. And that high prominence on the right side is what's associated with the curve pointed to the right. Similarly, if the curve is lower in the back by, we call it the lumbar spine. So the thoracic spine is the part that's in your rib cage. Cervical is in the neck. Again, thoracic in the rib cage. And then lumbar is below that. So if the curve is primarily in the lumbar spine, when your kid bends forward, you may notice that the muscles on the lumbar spine, like in that area, they look higher or they look bigger than the other side. And it's not that the muscles are different. It's because of the rotational difference or asymmetry that occurs with scoliosis. And so If there's any concern on the screening exams, then you would come and see us in the office. We would get a full history. In girls, we always ask about your menstrual history because the first period does signify typically when a girl is going through their growth spurt. And with scoliosis, we can see that the curve tends to get bigger when kids are growing really fast. So that's why it shows up usually in like the pre-adolescent years, like 11, 12, 13, because kids are having these sudden periods of growth, and then that's when the scoliosis progresses. And then as the growth slows down, then the curve typically does not get bigger after that. So treatment for scoliosis is dependent on your age, your skeletal maturity. So sometimes your chronological age does not match your bone age or how mature your bones are. So it depends on your age, your skeletal maturity, and then the size of the curve. And so typically for curves that are less than 25 degrees, we just watch them. We don't do any bracing or talk about surgery or anything like that. Sometimes we can give you a prescription for a type of physical therapy that is directed towards scoliosis. But overall, the treatment plan would just be for you to come back, every so often for us to check x-rays and to make sure it hasn't gotten bigger. Now, if it got to between 25 and 45 degrees, we would talk about bracing. And that is because bracing can help prevent a curve from getting bigger, only if you're still growing. So bracing is done only for kids who are skeletally immature or younger. If you're 16, 17, and pretty much done growing, if you're a girl and you had your first period like 3 years ago, we're not going to put you in a brace because the brace isn't going to do anything for you. When you put on the brace, obviously it pushes on the curve, gives you some correction. We get an x-ray in the brace and it shows your curve is nice and straight. But as soon as you take the brace off, the curve should go back to where you started. So again, the brace is to prevent the curve from getting bigger as you grow. So if you're not growing anymore, the brace is no longer needed. If your curve was 25, 45 degrees, 25 to 40 degrees, and you're done growing, then we would typically just watch you because we don't tend to see these curves get bigger even when you're done growing. Now around that like 45, 50 range, that is when we would talk about surgical intervention. So, sorry, on the top picture here, this is an example of a brace. There are different types of braces that can be used for scoliosis, but this is just one of them. Now on the bottom picture, this is a picture of a surgery that's done for scoliosis. So for curves bigger than 45, typically 45, 50 degrees, even when you're done growing, the curve will slowly get bigger as an adult. So that's why we recommend surgery, because we don't want you to have, issues as you continue to grow older. The goal of surgery is, one, to make you straight, but two, to also fuse the spine in that position so it doesn't continue to progress. Surgery is done, at the hospital. It's fairly routine. You would be in the hospital for maybe a couple nights after surgery, just depending on how you're doing. There's a lot of different checkpoints before you're able to go home. But it's something that we're able to do now with excellent techniques and different ways to make sure that you're safe. But again, those are only for bigger curves, so nothing to worry about if you're just getting screened or sent over for scoliosis evaluation. So thank you so much for joining me for the last 2 sessions. If you like these talks, I'm happy to put together more talks. If you have any specific topics of interest, please feel free to let me know. All right, thank you.